So my topic for the day, to open up 2 days of an implant program, and you're going to be hearing quite a bit in the next few days about augmentation. We have some amazing surgeons, prosthetics, aesthetics, team therapies, and you start a program on a downer. I talk about complications. That's kind of backwards. Aren't you supposed to show the successful cases and then at the end of the meeting show the complications? Well, we thought about this and said, since most of the cases that we see that challenge us, that bother us, are the ones that didn't go well, that didn't go right, and what do we do now? Whether it's your own cases, whether it's a referred case, the problem exists in your chair, and how do you manage it? If you take a look at this image here on the screen, obviously a boat heading into a storm. I'm sure the captain of this ship maybe didn't realize that that storm was moving that fast. And what does he do now? What does he do with the ship? Does he direct it to the right, to the left? Does he stop it? Sounds like something that we have to do with our own cases. So what we're going to do is basically look at cases, in my little time that I have with you, look at cases and how we take a complication and dissect it. Try to break it down and try to come up with strategies. I don't have a lot of time today, and I want to keep us back on a pretty good schedule because we have a lot of speakers, but I'm going to try to do, in my time with you, to show you how there are strategies that can manage some of the most significant complications, and most of them are going to be a combination of implant maintenance and, of course, also disinfecting, recovery, bone grafting, and, of course, maybe the most critical of all of those is soft tissue management and augmentation. And I think that's a really critical area for you to get comfortable with. One of the most interesting things that I see when I got on the lecture circuit and I'm in the educational forum is there's more of an interest in bone augmentation. People want to learn about how to grow bone to place implants. Yet most of the failures that I have seen have been really soft tissue related. Flap management, lack of thick tissue, bone, membrane exposures, all of those things can be catastrophic for what you're going to end up with in your final restoration. So we want to avoid those things, and really for us doing that with soft tissue is going to be critical. So what I want to share in the next, hopefully next 45 minutes, is these strategies and how we actually manage them. So how do we manage complications? One of the first things that you're going to have to deal with implants being so routinely utilized today is even a young lady who just a few years earlier had implants placed for congenitally missing lateral incisors. Implants were placed, the crowns were inserted, they actually looked quite good. And she comes back after a few years and we see a situation break down like this: suppuration, radiographic evidence of bone loss. You can see a small little fenestration through the soft tissue. And now the whole cycle begins. You have a young girl in her mid-20s. What are we going to do? What's our best option? And how do we deal with not only the physical issue, but the emotional issue for the patient and her parents? What we try to do is look at the case and break it down in terms of the vitality and longevity of that implant. One of the most critical aspects that we've always talked about is whenever we look at these situations is where is the interproximal bone on the adjacent teeth and how do we manage the infection? So the focus goes from not only what we see clinically in the suppuration and soft tissue, what we see radiographically, and where is the available bone most critically on the adjacent teeth. Probing, even after laser debridement, one of the first things that we want to manage is the infection. So when you triage a patient, pain and infection, those are the first two things we want to think of and take care of. So we put the patient on antibiotics, we treated it with a Nd:YAG laser, and we have some resolution of the infection, but you can see still a fenestration in the soft tissue, still significant probing depths around the implant. And luckily for us, when we probe along the adjacent natural teeth, the bone is very close to 5 millimeters, 5.5 millimeters from the contact point. So even though we have a little bit of the embrasure, the papilla area open, we don't have rampant bone loss on the adjacent teeth, which is critical. Flap access and careful debridement of the surface. We don't promise these patients that the implant is going to survive. I think it's very important when you have an ailing, potentially failing implant that we don't overpromise the patient. So one of the first things we do now is go in and tell the patient we're going to do an exploratory, and we're going to also debride the case thoroughly, and then we're going to make an evaluation of whether or not that implant can be saved. Once again, if you're looking at this, we try to minimize flap reflection. Remember, this papilla was already a little bit starting to retract a little bit. We don't want to open that any further, so we tunnel underneath this mesial papilla, we expose the implant, and we do a very careful debridement. What we try to utilize is an air abrasion. We use aluminum oxide particles, very similar to what's used for implant surface preparation. And then we'll also place tetracycline on the implant surface. Once it's been cleaned, we leave that on for 3 minutes. Some people use citric acid. And then we also use an Nd:YAG laser at low energy to remove the toxins on the implant surface. So again, the tetracycline is applied. We leave it for 3 minutes. Again, citric acid can also be utilized in this fashion. And then an Nd:YAG laser on low power setting, about 5 millimeters away from the implant to remove the toxins. Once that is done, an attempt to reconstitute the labial bone utilizing bone grafting material. This is a mixture of mineralized irradiated bone and growth factors from the blood, plasma-rich in growth factors, fibrin, collagen membrane, and then most importantly, soft tissue augmentation. Taking tissue from the palate when you're going to graft around implants. This is a small point. I never say always, I never say never, but for me, almost always, around implants, I choose autogenous tissue and not dermal tissue. I know people ask that question. I use dermal tissue quite often, but this wouldn't be an indication. So autogenous tissue, which gives you a vital source of cells, we try as best we can to coronally advance the flap, secure the graft in position with an anchor suture, and then advance the flap over the tissue and bone graft material. 4 months, we can see that we now have a thickened keratinized tissue layer. We're having very good healing. Patient doesn't show any signs of infection. We don't want to probe this area for at least 6 months. And at 6 months, the patient was doing very well, and that implant now survived. Let's take a look at an even more substantial issue with multiple implants placed in the aesthetic zone. This is a patient that presented to the clinic in Atlanta almost 15, 16 years ago, and had 3 implants restored after bone grafting. Pregingival grafting was performed, and this restoration was in the mouth for about a year. Look at what has happened in that time frame. Significant tissue recession. The patient reports the abutments were not exposed at the time of restoration, so this has continued to digress over time. And now the patient is very concerned. She has a somewhat high smile line. She doesn't like the aesthetics. She's concerned about the opportunity for us to be able to solve her aesthetic issues. So this is again, ailing case, maybe not failing. We want to really scrutinize the radiographs. So you go from evaluating the tissue, patient's not in pain this time, and the patient doesn't have any suppuration or very obvious infection. There is radiographic bone loss all the way down to the first or second threads of these implants, but it does not seem at this point that we have any periodontal infection that we're dealing with. So when we start to look at this case, what are some of the issues that may have been the cause? And what are some of the things that we look at that may assist us in being able to solve the riddle? One of the first things we like to do is, when possible, remove the restoration. I think one of the best things you can do with a failing implant, if possible, if you have a screw retained restoration, obviously it's easier to remove the prosthesis, remove the abutment, and work at fixture level. The prosthesis was removed. You can see a wax-up that was done, a mock-up of a future idea for the patient of where we'd like to have these teeth in relationship to the tissue. And you start to get more of an appreciation of the significant amount of soft tissue that's missing. That's where we want the restorations to be, but certainly don't have the soft and hard tissues to support it. Many years ago, we published a paper on the interproximal height of bone as a prognostic indicator for future tissue levels. And this is on Dental XP. You can certainly download it for you, but we use this almost each and every day. This is a very important chart because it tells us with every possible fixed restorative environment in the aesthetic zone, what are the proximity and vertical expectations? What are the proximity spacing needs required? And what are the soft tissue levels between every type of fixed restorative option, whether they're teeth, pontics, or implants, or any type of solution that you may come up with. So if we look at a case like this one, and you see that multiple implants were attempted to be utilized in the aesthetic zone, you have two different issues you'd have to look at. One would be the fact that very difficult to segregate implants by 3 millimeters, something that Dennis Tarnow first published on in the Journal of Perio in 2000, and then that the mean expectations of tissue levels between implants is only about 3.4, 3.5 millimeters, an article that we published with Dennis and his group here at the time at NYU. And if you see that you have the measurements to support the tissue levels, then maybe that's something you want to attempt. But obviously, in this case, when we measured down to the bone levels, to the height of the tissue, the measurements were way beyond 3.5 millimeters. So obviously, solution with multiple implants probably isn't going to be a very good one. Instead, if you take a look at a solution here that we look at, we're about 6 to 6.5 millimeters away from the bone. So the best solutions we have would be tooth to pontic, but there's no teeth. The only other solution was classification number 6, which is pontic to pontic, where we don't have to worry about proximity limitations, and we can be as much as 6 millimeters from bone level and get added tissue height. And if you look at this case, 2.5 to 3 millimeters of tissue height is exactly what this case needs. One of the most interesting things about this case, when you look at the implants next to the natural teeth on either side, what do you see there is that the soft tissue remains. And the reason that that's there is because of the critical interproximal peaks of bone on the adjacent teeth that continue to support that soft tissue. So the dilemmas that we have are really what are our choices, what are our options, and what are our solutions. And depending upon what your comfort level is, there are many different ways to go in this road. One would be to completely remove the implants and attempt a reconstruction once again. Certainly today with counter torque removal systems, you can certainly attempt that. Obviously the defect would become larger, probably require an extra oral source of bone grafting once again. This patient had already gone through hip augmentation. What other options do we have? Can we save these implants, do what we did on that last patient, disinfect it, graft it, place tissue and come back? Maybe. The only problem with that is that we're still stuck with 3 implants being next to one another. One of the options that we considered here was to do what we did in the last patient. We disinfected the implant surfaces, we kept them in the mouth, we went ahead and placed healing abutments rather than cover screws to assist us in coronal advancement of vertical augmentation of the soft tissue, and then we added autogenous connective tissue like we did in the previous case. And this is something we first talked about over 20 years ago in the Journal of Aesthetic Dentistry, 1995. We called it guided gingival regeneration. As opposed to GBR, this is GGR. So the concept is create the space for regeneration, but don't place a membrane. Allow the blood clot and connective tissue to have an opportunity to stabilize and fill the area. And we found quite a bit of success doing it in this way. We went ahead, released the flap, did a very, very significant dissection to be able to move that tissue down over the healing abutments and completely submerge them. David went ahead, made a temporary restoration with ideal pontic forms. We utilized 6-0 PTFE sutures. And about 4 months later, the patient came back from California, and all of the implants had remained underneath the soft tissue. Our ability to manage flaps, to add thickness of keratinized gingiva. We're not so sure how well the bone augmentation has gone, but there's no signs of infection, there's no pain, and all of the tissue has been altered through augmentation. So the levels aesthetically have been improved dramatically. You now have scalloped form around a bridge as opposed to the implants. We go back to verify as part of our study. We take 30 gauge reamers, we take rubber stops, we measure from the bone to the tissue height, and again, what we found in our study is roughly 6 millimeters, what we should expect. Sometimes the range could be as much as from 5 all the way to 9 millimeters. So there's been quite a different range that we've had, but as an average, I would say you should consider about 6 millimeters from the bone height in terms of what your expectation should be clinically in your own cases. Now the patient has somewhat more uniform and aesthetic restoration. You can see when she smiles, she no longer shows metal. And again, even on a lateral view, which may be even more important, you don't see that difference, that dieback towards the implants that you saw earlier. From a lateral or buccal perspective, you don't have a concavity in the ridge. And we've taken a patient who is very disappointed in her implant restoration and altered it using conventional bridge, soft tissue augmentation, sleeping, in this case, sleeping the implants. So last patient, we kept the implant. This patient slept the implants. The big question that you often are asked is after 6 months healing, before Dr. Garber places the bridge, the patient says, hey, I'm just asking, why can't we go back in and use the implants? And the challenge that we have is that if we go ahead and punch through the tissue that we created and re-expose the implants, the opportunity for us to have the issues related to the environment, having consecutively placed implants, the closeness of those implants together, the dieback of bone, once we restore it, would leave this patient once again at risk. Not to mention the inclination of the implants, the labial position of those implants. So you got to be very careful. In an ideal environment, it may be possible maybe to expose the lateral implant and the opposite implant here and leave this as a pontic. That was considered, and that's something that David and I and Henry looked at each other and said, what do you think? And when we exposed the implants originally, we took an impression, gave it to the laboratory technician, and the laboratory technician said, it's possible the problem you have is the labial position of the implants. So I think it's still a risk from a restorative standpoint. So sometimes the risks are surgical and sometimes the risks are prosthetic. We ended up going ahead, taking the case and finalizing it with a conventional restoration, multiple pontics, as opposed to an implant-supported restoration. So David often mentions what the critical restorative gingival interface, really where you put the tissue defines where the laboratory and the prosthodontist can predicate where the restoration is going to be. So the critical interface is really predicated upon where we leave the pink part of the soft tissue in terms of the final restoration. Here's another lady that comes in to see us and also very disappointed in her restoration. She has an older implant. You can see that it's discolored. It's also at uneven levels and margins. And again, we're left with decision making. And often one of the decisions we make for this patient is we don't have an infection, we don't have pain, we have a patient who's disappointed in the aesthetics. It's gotten worse over time. And how do we actually manage it? And one of the hardest things that you're going to have to do is to explain to patients often it can't be solved just by dealing with the single implant issue. The implants in a partially edentulous patient, you often have to include the adjacent natural teeth in your solution. It's sometimes something the patient says, well, wait a second, I don't really want to take care or involve the other teeth. It's actually even more challenging when those teeth are virgin, intact teeth. In this case, you see these other teeth have been restored, and often something needs to be done on the adjacent natural teeth in order to optimize lip to soft tissue aesthetics. What Davis said was the interface, the gingival restorative interface. I think by now everybody's pretty much seen this, or the concept, digital smile design, or DSD, something that was created by Christian Coachman, Guy Cabral, while they were actually with us in Atlanta. And this is really a very nice way to give the patient and the team an idea of where we want to end up in the final case. It's really a very, very simple but very, very elegant way of giving the patient an idea through a mock-up. A wax-up is done, and we can now have a mock-up of where we want the final restoration and give the patient an idea of where the final case is going to go. And that's something that Christian did beautifully, transitioning from an analog to a digital world in terms of sharing information and getting the patient on board. And we have Andrea and Alessandro Agnini, who did a beautiful book they published last year on digital dentistry, digital revolution, and Christian was one of the guest co-authors, and I certainly encourage you to take a look at their textbook. It's outstanding. So here's the problem. We encourage the patient, she's on board, she says, yes, I want to do this, but she has expectations now of having a more harmonious and even gingival symmetry in the final outcome. So one of the first things that we look at, here you see one of the problems with this case, not only is that the implant has lost some tissue and we have some discoloration, but the angulation of the implant is very much prominent and towards the labial aspect. That puts an additional issue on us. What is the prognosis of the right central incisor? Can we save that tooth by restorative and endodontic means, building a post and core on it? And we start to break down this case. Very similar to the last case, but maybe in a lot of ways somewhat different as well, because we're involving adjacent teeth and changing tissue levels. One of the most clever things that I've seen, and he's seen so many from dentists, Dennis Tarnow suggested that in these kinds of cases, before you start the whole process of augmentation, simply make the new temporary, remove the abutment from the implant, and place a cover screw. Look at the discoloration. Look how thin that tissue is. And we now expose the implant, place a cover screw, remove the abutment, do nothing else. Just simply make a new temporary, and it closed over almost completely just by soft tissue ingrowth over the cover screw. This is certainly a lot better situation for me now to do the second surgery using a much longer flap and more dense keratinized tissue in this area. So take a look at what we're looking at. Look at the symmetry in this area. It's quite significant. Look how altered this is. Yes, it's functional, no pain, no infection, but this is an aesthetic concern. Patient's in her mid-30s, doesn't like the aesthetics, high lip line. What are we going to do? We're going to do a combination of crown lengthening on the adjacent teeth and soft tissue augmentation on the central and lateral incisors. We're going to use different tissue grafting materials. If you're going to graft over an implant to hide or bury it, my preference today is to use tissue harvested from the tuberosity. It's dense fibrous tissue. It doesn't have the lipid content, the fat to shrink that you see very often. So this material I use over the implant. This connective tissue from the palate I use over the lateral incisor. So I double it up. I place it over the implant, leave the cover screw in position. Here's the tuberosity graft, and here's the connective tissue from the palate, palatal graft, and then an advancement of the flap using PTFE sutures to completely submerge the grafted area. I'm going to pause for a second and tell you, not a general rule, I think your best results, whether it's in a complication case or a regular case, is when you can keep all of your graft material submerged, whether it's a bone graft, whether it's a hip graft, titanium mesh, or soft tissue. If you can work in a submerged, closed environment, you are going to get your best results. Open environments, where you have a sulcus, you have a crown, a healing abutment exposed, always going to be less optimal in terms of healing. Take a look at the healing here now, just at 2 weeks. Sutures removed, very typical with PTFE, no wicking, no inflammation. Look at this early stage augmentation. Because of a closed environment, we are able to get optimal wound healing here. And now we can start to see this over time. Now at 3 to 4 months, patient comes in, she obviously wants us to be able to use this implant, so we're going to go ahead from here to here. But how do we do that? Do we just punch a hole through there and pull out the cover screw and place the healing abutment? We do it very, very carefully. We don't want to throw this tissue away, so we de-epithelialize it. We use bendable microblades, and we're going to take this tissue and roll it underneath for further augmentation in this area. Only then can we insert a custom abutment and reline the temporary to reestablish the contours. And here's the case as they were finishing it up, putting the final crowns on. Here's the right central incisor that we were able to save. You have at least 2 millimeters of a ferrule. And now, with the crown lengthening, being able to reestablish the contours. Look at this thick tissue now over the implant, and look at the contour of that soft tissue developed in a much nicer way. So using crown lengthening and augmentation to redefine the aesthetics, using digital smile design to give the patient an idea of where we're headed, and giving the team an idea of where we'd like to be at the end of the case. From a standpoint of these types of situations, it's a little area of tissue. I don't want to get too caught up in this, but for this patient, this is a real issue. She's very unhappy with it. She's rather young, and you can see when she smiles, she's not really fond of her restoration. She tries not to smile and show the metal underneath her lip line, and she wants to know what can be done. And again, I'm going to try to do the most minimally invasive procedure I can do, because I don't want to alter the interproximal levels around my implant. So if you're going to graft over an existing implant, one of the things, and leave the crown in position and try to work with that restoration, one way to do it would be using the Vista technique, something that's been shown very beautifully by Homa Zadeh. And I'm going to repair this again with autogenous tissue, and we're going to transfer that tissue, rather than through a vertical incision, through a horizontal incision at the mucosa level, mucogingival junction. We're going to coronally advance this, completely submerge it underneath the outer flap, coronally advance it. This is at 2 weeks at suture removal with the temporary in place. This is now at 2 years. Not perfect, but certainly much improved on where she started, and another potential option for this long term. So this young lady now much more comfortable smiling, and certainly a much better final solution. So when we start to look at cases, think of tissue thickness. As much as anything else, when you're evaluating an area for bone grafting, think of how much tissue do you have, how much keratinized gingiva do you have, and what could be done to alleviate. How about when a papilla is missing? Here with a resin bonded bridge, papilla on the distal of the implant, mesial of the canine is not there. We focus on this area. Is there another aspect that we can use? We're going to use palatal tissue and tuberosity tissue in conjunction. We're going to use, again, this horizontal approach, using more of a defined instrumentation now that's available for the Vista procedure. We're going to place our suture through the tunnel and pull this graft into position, and we're going to release the papilla to be able to place this graft through here, that tuberosity tissue, and try to anchor that right in this area where the papilla is missing. And this is the early healing of that situation. You can see the tissue is bulked up. One of the nice things about this tissue, it's very redundant. And at the end, although it's not a perfect solution, it certainly improves that substantially. So tuberosity tissue, tunneling procedures, these are also ways to do that. And then this can be taken to the digital world, making the final crown and working that out. What happens when the implant doesn't give you any option? This patient had 2 implants placed in the central incisor region. She comes in saying she doesn't like the way it looks. She's upset, but it's also hurting her. Well, we take a look at this. Certainly it's an aesthetic failure. I think we can agree with her. There's no attached gingiva to speak of over the implant. We have soft tissue recession. We have an aesthetic concern. When we probe, the probe goes all the way down, almost 12, 13 millimeters. So we have bone loss, that's substantial, especially on the labial aspect. And she also mentioned something that's even more important. The implant's mobile. So we know that there's one thing different. It's either the abutment or the implant that's mobile, and in this case, it wasn't the abutment, it was the implant. So we have an implant that's failing. And when we take this implant and remove it, although we have an aesthetic failure, we have to start considering the adjacent teeth. What are we going to do? Are we going to do some crown lengthening here? What are we going to do on the lateral incisor? They're virgin intact teeth. What's the most ideal way of restoring this case? One of the first things we have to do is the implant's fibrous encapsulated, so we're going to place a healing abutment on it and counter torque it and just remove it. And this is a pretty long implant, came out very easily, but it left behind absolutely significant soft tissue issues. As I said earlier, the first thing I do with a failing case is I don't overpromise the patient. I don't tell them, yes, don't worry, we'll take the implant out, graft and put another implant. I don't tell them we can save an implant. I tell them that the first surgery most often is going to define the case for us and give us the information of what is the possibility of a solution. So don't put yourself in a corner with the patient, because patients will remember, well, you told me that you were going to save my implant. That's not the case. The implant's going to be removed, and we're going to evaluate how much is left behind. And what are the things that we look at here? The interproximal bone on the adjacent teeth. Always know where that bone level is, because if those teeth are involved, this is a completely different situation. Second thing is going to be, how much labial destruction do we have? In this case, unfortunately, multiple implants had been placed and failed. This patient had a cleft-like defect in this area, didn't want to go through bone augmentation and implants again. So we took tissue from the palate. I actually rolled this tissue up and sutured it with a chromic gut suture, and then placed it into this area because I had no keratinized gingiva. So I wanted, first thing is to try to get myself some keratinized gingiva to work with. Implants removed, fibrous tissue removed from the area, tissues placed, and I use a little bit of a releasing flap here. This is split thickness. I leave this open, and I use this tissue laterally to help me cover my graft completely. So sometimes it's not a coronally positioned flap that covers it. Sometimes you're going to use a lateral pedicle. Whatever you need to do, this is going to heal fine. But this little extension of this flap to cover that tissue helps the healing in this area. This is what it looks like early healing. You see how nicely that area healed where we did that split flap. Now this allows that tissue to heal very nicely. I can take the sutures out, and about 3 months later, I do a vestibular extension and a laserplasty of the new tissue. Patient's been in an Esthetic retainer with a tooth, much like an Invisalign tray, and we take a look at what we were able to achieve. The next question for us is, what else do we want to do on this patient? For me, the options were to rebuild this area with bone. The patient wasn't interested. Second option was whether or not David would be able to reconstruct a restoration that would make the patient happy. And the option here was to go with a fixed bridge. Here's the Essex in place. You can see the patient had a high lip line. This is a simple way to keep pressure off the ridge while we're doing these augmentations. I certainly suggest it. I use a Essex material from Raintree. It's a subsidiary of Dentsply, I believe, and I use the 035 thickness and simply place a denture tooth in there. David went ahead, prepped the teeth, created an ovate pontic, trying to see if he can shape that tissue. I think she was very happy. He was able to do a very nice job just with a little bit of gingivectomy on the right central, trying to recapture some normal contours. And this is what the area looked like. This is at 9 months. And this is, again, conventional restorative dentistry versus bone tissue reconstruction of the site. The framework is inserted, and you can see from where the patient started to where she ended up with a conventional bridge. So in many instances, in severe situations where we've had multiple failures, not only from a physical standpoint, an anatomic standpoint, but an emotional standpoint, we want something that's going to be most predictable. And we still have restorative dentistry, conventional restorative dentistry, and ovaponics as a solution. A patient who had a failed implant in the central incisor position, young lady who was a student in Atlanta. She had traveled over from South America, and you can see that this defect is through and through, from the buccal all the way to the palatal. She was very, very concerned, and obviously we had to try to come up with a solution for this one. The implant in that area failed, causing a very severe defect. And what we try to do again is to start with tissue. And one of the things that we did here, since we had no attached gingiva, this is mucosa all the way down, from the lip, this is the frenum, all the way to the palate. So what we did here is we do a bed preparation. I take a diamond burr, curettage burr, and I remove the outer epithelium of about 0.25 to 0.5 millimeters to get exposure of the underlying connective tissue and to get bleeding. We also do a bed preparation for free gingival graft to get a vestibular extension. We then take a free gingival graft, not connective tissue. We take the epithelium and we take the connective tissue. Very thick graft. This is an onlay graft, something that Jay Siebert made famous back in the 80s, and we suture it into position and stabilize it. And this was at 10 weeks. Better, but still, she's not very happy. From an aesthetic standpoint, we didn't get enough. So what are we going to do now? At this point in the case, I think the decision has to be, and many times I think one of the things I can give you as advice is when you are grafting in a case that came in as a complication, never promise the patient it can be done in one surgery. Often there's multiple procedures and revisions that are required, and we should tell them from the inception that most likely it's going to take multiple procedures. We did that with this patient, suggested in this case we would use connective tissue from the tuberosity. We'll use a double pedicle plus the CTG that we use, and we're going to advance the flap over that dense tissue. And I think that this is a concept. If you can anchor this tissue at the crest, you can get vertical augmentation. And there's a lot of different ways to do this. Giovanni Zucchelli calls it an island graft. He uses it for ponic sites where he needs vertical augmentation. This is sort of a similarity. I anchor it. I make sometimes even a small hole in the bone and suture through the hole in the bone to anchor that tissue right at the top of the crest. And then I did two releasing incisions on the palate so I can rotate the palatal tissue as well, so I can get closure from the palate and from the labial aspect. And this is 10 days at suture removal. Look at the vertical component of the soft tissue that we were able to graft. Remember where we started. There was no vestibular depth, no attached gingiva, and there's a cleft. There is no bone on the palate, and there is no bone on the buccal. But because we have interproximal bone on the adjacent teeth, we really have a different type of situation where we can really focus on a restoration. Here, we went ahead with a Maryland bridge, resin-bonded bridge, and the patient was quite happy. So being able to really take a defect like this one and transition a patient who had a failed implant to a conventional restoration is another option. So we're dealing with many different environments, and if you look at these cases, you really need to have a lot of different tools at your disposal. I told you some of those options. Some final case for my presentation. This is a case I treated with Henry in Atlanta, a patient that had come in to see us, actually was in the dental industry, was one of the national managers of one of the major implant companies. The implant failed, had another implant placed that failed. The patient came back to see us, and when we looked at the case, one of the first things we want to do again is to get an idea of what is the volume of tissue that's missing and why is it missing. Most importantly, where is the bone? Remember, we keep talking about where is the bone. So not only do you look in the mouth, you have to really look at the radiograph. Where's the bone levels? And if you take a look, we have very, very good interproximal bone on the central incisor, but on the lateral incisor, on the mesial wall, we're missing quite a bit of bone from the contact point all the way down to to the bone levels. We're about 6.5 to 7 millimeters. So this area now adds a different problem to this case, a different complication. Remember the previous case, very big labial-lingual cleft, but no interproximal issues. Here, we have a labial problem, and we have an interproximal issue. And typically for us, the interproximal height of bone, as a prognostic indicator, this would be a class 3 situation, a type 3 restorative receptor site. So if we're going to try to get an aesthetic result on this gentleman, and remember, he works in the implant business, we don't want to make a mistake here, or who knows what he would end up telling people. But we see that what we're missing here is a large volume of tissue interproximally, and we have a concavity on the ridge. We want to regain balance. This gingival margin is higher than the left central incisor. So we have an aesthetic issue not only with the defect, but with the adjacent natural tooth. So it's not just an implant complication. The failures of those implants have very often will cause bone loss and tissue loss on the adjacent natural teeth. So something to consider. Define what's missing and what the reason is. Very simple way to do DSD. We take the tooth here, and we just simply outline it. We flip it, and we move it over to the opposite side. This is something that Henry did, just designing it maybe through Photoshop, taking the tooth and doing that. And now you really know what's missing in terms of soft tissue. This is a clear definition of what we want to restore for this patient. Once again, at that point, soft tissue augmentation and rebury that tissue area, make sure it's a closed healing environment. We reevaluate the area, placed an implant, came back after the implant, osseointegrated. Henry made a temporary restoration. And what we did is we used orthodontic extrusion on the left lateral incisor to bring down the papilla, that interproximal bone that was deficient. We can't grow it with implants, but we can't do it with bone grafting, but we can with orthodontic extrusion. We can't do it with bone or soft tissue augmentation. So one of the final things from me as a toolbox is we looked at laser disinfection, hard and soft tissue augmentation around implants to save them, replacing them. The last little part of our puzzle was trying to reestablish the tissue height on an adjacent tooth that had been affected by an implant failure, and to do so, orthodontic extrusion. When you're missing a papilla and you have a tooth that's adjacent to that site, that tooth is going to be key, and using it for orthodontic extrusion will allow you to reestablish papilla height. So here, in this case, we went ahead, we used nickel titanium wire, very, very passive, like 012 or 014 NiTi, and slowly erupt the tooth. You can see we take it out of occlusion. If we can dim the lights a little bit there. We go ahead and we extrude beyond the amount of tissue we need. And I'll share with you the last tool before I end my lecture. You can see as we brought this down, the papilla, not only the tissue interproximally, but also the tissue on the labial comes down with the tooth and movement. We make sure there's no trauma from occlusion. We move the root closer to build that tissue in this area, the papilla. And then we stabilize this for 3 months. It has to be stabilized. You can do it with an arch wire. You can do it with resin on the lingual aspect, rib-on, but you must stabilize this. But take a look radiographically what was able to be achieved with this lateral incisor. We took the bone that was present. You can see the grafted particles from the implant surgery. And by moving it orthodontically, we were able to bring that bone down to reestablish the soft tissue interproximally. So that little bit of bone manipulation done orthodontically really saves this case and allows us to create this type of soft tissue solution. Now, this tooth, after extrusion, we have to wait and evaluate its ability to withstand itself as an abutment. And this tooth was still somewhat mobile. There wasn't a lot of root left after the extrusion and all the surgery that was performed, but we were able to bring down the tissue. And obviously, one of the issues we have are, what are you going to do with the lateral incisor? So here, a little bit like the question that was asked. One of the options is, why not take out that lateral? You erupted it, it's loose, it's mobile, can't stand on its own. Why not place another implant? Well, we know the issues. We would create what we call the lateral central dilemma. Problem with spacing between these implants, the problem of losing that papilla, something that Dennis Tarnow published many, many years ago. And what we decided to do is, rather than place another implant or use the tooth as an abutment, we submerge the root underneath the bone, maintaining the bone around the root, maintaining that very important interproximal bone, and then place soft tissue over the top and used it as an ovate pontic. And this is something that we published on over 10 years ago. We called it the RST, or root submergence technique, for bone stability and aesthetics in very demanding anterior implant aesthetic restorations. This was the publication. If you want to take a look at this article, you can find it on dentalxp.com. This is something that we published with our friends and colleagues in Japan, Tom Ishikawa, Aki Funado, Henry and David and myself. And really, for me, this is one of the articles that really led to a lot of the concepts you're going to see over the next couple of days. I'm sure Jorge Campos is going to show you some concepts related to PET, what we call partial extraction therapy. I know Howie Gluckman's going to be talking a little bit about that. A concept that I believe has evolved substantially on the forum at Dental XP. I think there's as much clinical research being discussed and changed on that site. And I'm very proud of what you're going to see from those two colleagues during their presentations. So, as a summary, what are your choices, options, and solutions for these types of issues? And I think you really have to look. I said pain and infection, handle that first, triage the patient. Number two, don't overpromise. First surgery is going to lead you to what you're going to want to do. Don't promise the patient you can save the implant. Don't confirm that it has to be replaced and removed. Do the first surgery, clean the implant surface, evaluate where the bone is, and make your decision. You can use different forms of connective tissue, palatal and tuberosity. You can use vista and tunneling techniques and microsurgery to really rebuild soft tissue. And soft tissue, to me, if I had a choice between thick bone and thin tissue, or thin bone and thick tissue, for me, I take thick tissue and thin bone any day of the week. And that thick keratinized tissue can save us in many of these situations. Consider orthodontic extrusion when you have an interproximal issue on an adjacent or neighboring tooth. And of course, a root submergence technique and ponics is something that I think has been an emerging discipline, and it's taken off with socket shielding and pontic shielding and partial extraction therapy. And with that, I just want to thank you